Good afternoon and welcome to today's SAMHSA-sponsored webinar titled Innovative Initiatives to Serve the Needs of Older Adults with Serious Mental Illness, presented on behalf of the National Association of State Mental Health Program Directors Research Institute, also known as the NASBID Research Institute or NRI. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be seen spotlit on your screen. During the presentation, please add your questions and comments into the chat box, and the questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please take a few moments to complete a brief survey that will show in your browser as you exit the platform. Thank you again for joining us, and we will now begin today's presentation.
Hey, thank you so much to everyone for joining us this morning, or I guess noon if you're on the East Coast, as many of you are. So I'm going to open up with a very brief overview to motivate what we're talking about today, which I don't think needs much motivation. That's why you're all here. But to give you some numbers, and then to turn it over to my very esteemed colleague, Nirmala Dhar. So the first question I want to bring up is really is a question indeed. What is an older adult? And I think this is something that it's not as clear cut. We often talk about transition age youth, but we can say, okay, you have a child, then they turn 18, they're an adult. What's an older adult? You have to be 65 before you can get Medicare, of course. That's an important milestone, but many older adult act services can be accessed at younger ages, at 60, in some states at 55. And then when we consider the intersection with serious mental illness, we have to think a little bit more broadly about what constitutes an older adult. It's not just a number, it's not just an age. People with serious mental illness, as we know, age faster than people without serious mental illness. And so as we're thinking of what age we should be providing services to, we maybe should be shifting that to a younger age if we want to really reach people with serious mental illness in a way that we can help them before their condition deteriorates due to age-related, accelerated age-related illness. And so that's one question. So what is an older adult? And that's something that you'll see throughout Nirmala's presentation. Now, their services are not just for people 65 and older. And then another thing I want to bring up is I think many of us have heard the idea, and we know it and maybe see it in our systems, that there are more older adults out there than there used to be. And we assume that this trend will continue. And so what's interesting is when we look at census data, we certainly do see this trend, and I've looked at it up until 2050, and the number of older adults indeed increases. But we see this especially true amongst the older adults, people, let's say, over 70 or over 75 or over 85. Each age range you go up, the percentage of people in that age range increases faster. And so it's really the oldest adults who are increasing at the fastest age ranges. And interestingly, the people ages, say, 50 to 60, 50 even to 70, really won't increase much between now and 2050 as a percentage of the population. And so that's an important thing to think about when you're seeing who are you going to be serving in 2050. It's really the oldest of the oldest adults that you're going to see the largest increase in population. And another important thing to keep in mind is it also depends on your state. There's tremendous geographic variation in the percentage of older adults now. Certainly we can think of certain states such as Florida or Vermont, which already have older populations than average across the country. But this trend will continue and be, I think exacerbated is not the right term because there's nothing necessarily wrong with it. But depending on your system, depending on your state, your geography, you may see much higher percentages of older adults in your system than the average for either your state or certainly the country. So you have to kind of look at your own statistics to understand what the trends will be. And then the final thing I just wanted to bring up as kind of part of motivation here is that we're already seeing in the public mental health system a significant increase in the number of older adults. And so just to make sure I'm looking at the right numbers and not just making them up, we can see from 2006 to 2022, the latest year for which data are available, that the number of older adults, here defined as 65 and older, in the public mental health system were increased from 167,000 up to 337,000. And so that's really almost a doubling of the number of older adults across that time period. And so that is, it's not just something that's going to happen in the future. It's something that has been happening, and it's something that if your system's not ready for it now, well, it's not going to go away. And so that's where hopefully in Nirmala's presentation today, you can learn some useful tactics and ways to really embrace this change in our society, and something that we hope we all, of course, have the privilege of getting older. And so this is something we can make changes that will benefit us as well as individuals. So with that, I will turn it over to Nirmala Dhar. Thank you.
Thank you, Miran. Thank you very much. I am Nirmala Dhar. I am a licensed clinical social worker and have worked in the public mental health system, and I'm going to date myself here, for close to 40 years. Much of it in community mental health programs, often serving as the only geriatric mental health specialist. For the last 10 years, I am working with the Oregon Health Authority, which is our state level health authority. I work in the older adult, as the older adult services lead strategist. And in that position, I work under the umbrella of adult mental health. And also I'm project director and manage several state level programs, including a big one that I'm going to speak about, and also PASAR level 2 for serious mental illness. So thank you again so much for inviting me, and I'm very excited to be here to present the work that we are doing in Oregon as illustrative of really building that behavioral health infrastructure for older adults. So very briefly, I'm just going to add a little bit to what Miran so eloquently described in terms of demographics. Then really delve into some intervention points for services for older adults with serious mental illness, mainly focusing on coordination of care. Then discuss the process to determine specific needs and interventions. How do you plan for that? How do you fund those interventions? How do you build programs? And then we will look at what's the intersection of older adult services within our crisis systems. So I have several slides on that. And as I said, my lens is really going to be the work that we are doing in Oregon, and through Oregon Health Authority, which I'm very proud of. Next slide, please. And so, Miran already spoke about this growing population. And so my question to you is not just why focus on older adults, but really, it should really be why not focus on older adults? And here are some compelling reasons. Since 2011, every day, 10,000 Americans turn 65 years old. So that's been happening for 13 years. And this will continue till 2030, when the last of the baby boomers will turn 65. So baby boomers are essentially the generation born right after World War II. That means from 1946, and the last baby boomer was born in 1964. So it's a huge block, 79 million strong. And they account for well over 20% of the US population. And so it's hard to ignore that, correct? But often in my work, I see they are invisible, especially in behavioral health. And so again, my question is, why not focus on older adults? And despite their tremendous emotional resilience of older adults, and the majority are doing very well, there is a huge need for age-specific mental health services for this population, which is going to be the focus of our presentation today. Next slide. So here's the state of the state. As the older population grows, so does the number of older adults living with mental health and substance use concerns. Miran just pointed out how access for public mental health services has doubled between 2006 and 2022. Research shows that the majority of older adults with mental health and substance use disorders do not receive the necessary services and treatment, nor do they feel that these services meet their needs, even when they're offered. So expansion of these interventions to support older adults' mental health and overall wellness is a very important preventative measure. And I want you to keep that always at the back of your mind, this lens of what am I doing in terms of prevention? And so absolutely, this is critical. Next slide, please. So here is some data, and all presentations, we have to have a few numbers. And so, but again, I'm hoping that these numbers are compelling. And these come straight out of the SAMHSA report, which was just published, Behavioral Health Among Older Adults, results from the 21 and 22 national surveys on drug use and health. Look at mental illness. An estimated 10 million older adults had some kind of mental illness during that time period that I mentioned, that was 21 and 22. And from those 10 million, 1.5 had a serious mental illness. And from this group, females were more likely to seek treatment than men. And keep that in mind, because men are endangered species in terms of access to mental health services. So we need to give special thought to how do we outreach men. And from this 10 million cohort with any kind of mental illness, 2.7 million had a major depression or a major depressive episode. And that is a critical fact that I want you to keep at the back of your head in terms of what's the diagnosis that is most prevalent. So it is major depression. Next slide, please. So what was significant about that data among older adults with any mental illness who did not receive mental health treatment in the past year, nearly 95% did not think they needed it. 95%, from that 10 million cohort I spoke about. And this was similar for both men and women. About 1/3 of men with any mental illness received treatment compared to older women. So how can we intervene? How can we change this narrative? The big narrative here is that there's nothing wrong, I don't need treatment. And how do we engage men, older men in particular? Next slide. And so here was a study done in Oregon in 2022, where we were looking at what were our gaps in our substance use disorder services. And this is not particular to older adults, but it's for all adults. But I can tell you, you can compound this by 10 or even 20 when it comes to older adults, age-specific substance use disorder services. Look at, there was a 49% gap in services needed by Oregonians who had a substance use disorder. Most substance use providers lack the capacity to meet the demand for services, whether it was a workforce shortage or it was lack of knowledge and training. They essentially said we lack the capacity for all adults, but more specifically for older adults. And among Oregon Health Plan, which is Oregon's Medicaid plan, So among Oregon Health Plan members, less than half had been diagnosed with a substance use disorder. That means they had not been assessed or recognized as having a substance use problem and were certainly not receiving treatment. Because if you're not recognized or assessed for it, you don't receive the treatment. So as you can see, the need is huge for substance use treatment and for mental health treatment in general. Next slide, please. So here is the data from the same report that I mentioned earlier on alcohol use for older adults. 10 million older adults engaged in binge drinking in the last month. And what is binge drinking? It's 4 or more drinks on one occasion. So 10 million older adults. And then 2.5 million engaged in heavy drinking. And in terms of, there was a huge gender difference. Men were more likely to engage in both binge and heavy drinking. So twice as likely than women. And why am I bringing this to your attention? Because alcohol harms older adults exponentially greater than younger people. They have much more impact on their bodies, alcohol. And it can also exacerbate other medical comorbidities that they may be experiencing. So very important to keep this in mind, 10 million older adults. And the fastest growing trend in Oregon, and it could be in your state too, is binge drinking for older adults. Next slide, please. So with that said, my point today to make is that we not only lack adequate substance use treatment for adults, more specifically, we lack age-specific treatment for older adults for substance use. And there's an urgent need for it because, as I mentioned earlier, substance use has far greater harms for older adults than the younger cohort. Did you know that older adults are at greater risk of falls when they drink? In Oregon, 1 in 3 older adults falls and often breaks a hip or has traumatic head injury. So alcohol increases your risk. It increases your risk for worsening your depression. It increases your risk for 7 kinds of cancers. So it's really important that we get this message out on binge drinking and heavy drinking for older adults. Next slide, please. So again, what is the significant intervention point based on that data? I mentioned 10 million older adults engaged in binge drinking and 2.5 in heavy drinking. And look at it. In the past year, fewer than 1 in 3 received any kind of treatment, and 97% did not seek treatment or they think they should get it. So the vast majority did not seek any treatment, nor did they think they should get it. And nobody talked to them about it. Whether, most older adults go to their primary care provider, either their primary care doctor or nurse practitioner, and it is often not identified, assessed, or even spoken about. And it has a profound impact on older adult health and well-being. So that's a significant intervention point that we need to change. Next slide, please. And here is a general slide on clients or people receiving mental health treatment by age group. As you can see, the dark blue bar is older adults and the light blue bar is children under age 17. As you can see, we're not doing too badly with adults, about 73% in 22, or a little less than 73% were receiving some kind of mental health treatment. Again, this is not just older adults, but all age groups. Next slide. But I wanted to focus your attention on what are the top 5 mental health diagnoses. Look at it. The top 5 are depression is the first one, followed by anxiety, trauma and stressors, which includes PTSD, other mental health disorders, and then last, this light blue bar is schizophrenia and other psychotic disorders. So as you can see, depression is way up there when you look at both percentage and you look at the rate in the population. If you look at percentage, almost a third of our population, who comes in for mental health treatment, it is depression. And so you're going to hear me harp a lot on depression, and you will, we progress through our slides, you will see some of the work that we are doing in Oregon to address this and scale depression care. So again, I just wanted to point out what are the top 5 diagnoses for mental health. Next slide. And so, having looked at that, this is the take-home message: no wrong door for mental health services for older adults. Meet older adults where they are instead of expecting them to navigate complex systems and requirements. Meet them where they are. Keep it simple. Understanding and meeting our changing behavioral health needs as we age is vital to long life and positive mental health. And if we are not actively case finding, we're not actively identifying, older adults with mental health conditions are more likely than to experience poorer health outcomes, disability, frequent hospitalization, higher rates of nursing home admissions, occurring at a much younger age. You know, Miran mentioned earlier, the population that is really increasing are what we call the older adults, 75 plus. And there's a concept I just want to briefly bring up. We all know the concept of lifespan, and lifespan is expressed as longevity, correct? So what is our life expectancy? The life expectancy for an American male, and this is generic, is about 79 years old. And for women, it is about, I think it's 82. So that is life expectancy. There's another concept which I am really trying to elevate, is the concept of health span. How long do Americans remain healthy without chronic illnesses, including chronic mental health illness like depression, etc.? You know what the age is? 66. So we are leading, about 20 years of our life with 1, 2, 3, 4, even 5 chronic illnesses. And so our goal as policymakers and as we develop programs is to ask the question: how do I increase the health span of my older adult population in my state or my county? How do we compress illness, into the last few years of our life as opposed to 20 years? And so I want you to ask that question to yourself. What is the health span of the clients I serve? And does this make any sense? The no wrong door for mental health services. Next slide, please. And so the clarion call is meet older adults where they are by moving the front door for behavioral health to the community. Don't expect older adults to come to your clinic or come to your mental health clinic. Move your front door to the community, such as social service agencies, area agencies on aging, which are all across the United States. Senior centers or community centers, faith communities, whether they are the church or temple or a mosque, housing and congregate meal sites, with our emergency services, in long-term care. And we should all be maximizing our specialty mental health programs, such as CCBHCs, which are Certified Community Behavioral Health Centers, and our assertive community treatment teams. So again, the message, and primary care, because that is the front door for most older adults for mental health treatment and for substance use treatment, is the primary care setting. So again, the call for action is to move your front door into the community, where there is low barrier, easy access to effective mental health treatment for older adults, which is, by the way, age specific. Next slide. And so here is a strategy for improvement. Integrated and coordinated care across providers and systems. So it's not just the responsibility of public mental health. It is across providers and systems. Whether it is primary care, aging services, mental health services, medical services, across coordinated and integrated care. And really, really focusing on increasing the utilization of telehealth for behavioral health to close that access and timeliness gap. And yes, broadband is an equity issue, which we are all dealing with in some way or the other. And that, yes, digital literacy is also an issue for older adults population. So absolutely, those two issues need to be addressed. But telehealth is one way of kind of mitigating that access and timeliness gap. Second, improved education and training for providers in multiple sectors on the special needs of older adults with serious mental illness. And again, the emphasis is on multiple sectors. Did you know we train transportation drivers, Meals on Wheels drivers, aging service case managers, housing case managers, primary care teams? That is what I mean by training providers in multiple sectors. Third strategy, increased availability of health promotion activities to prevent and treat comorbid health conditions and mental health conditions. So we are actively promoting health and wellness with this preventative lens, so that we are catching these serious illnesses much earlier and intervening at a much early point. And then lastly, strong upstream prevention activities to address social determinants of health and risk and protective factors for well-being. So really working way, way up the prevention activities. What do we need to do to prevent suicide? What do we need to do to prevent social isolation? Have you thought about transportation as a key social determinant, both for mitigating depression, suicide risk, and dementia? So really working way upstream to identify what are those social determinants of health which have a profound impact on older adults. And let me tell you, wherever I go all around Oregon and actually nationally, transportation is way up there. Followed very, very quickly with, being socially isolated, which often happens when you lack transportation. So consider that. What are some of the social determinants that your older adults, your county or state are experiencing, and what are you doing to address them? So this is kind of a very brief blueprint on what you should be looking at, the 4 big buckets for strategies for improvement of services for older adults with behavioral health needs. Next slide, please. And so I'm going to quickly go through some critical pieces of Medicare reimbursement. You know, Miran spoke about who's an older adult. You know, one of the ages we look at is age 65. And for many people, it's a rite of passage, correct? It's your officially older adult. I am an official older adult. When you turn 65, you get, you know, you're Medicare eligible. And the good news is that there's this huge movement to modernize Medicare, especially as it pertains to behavioral health. And you all know that as of January this year, they expanded the licensure types that can serve, that can become, you know, Medicare providers to include licensed professional counselors and LMFTs, along with the earlier 2 licensure types, which were licensed clinical social workers and licensed clinical psychologists. So one way to really maximize reaching older adults is through this care management through Medicare. And the good news is you get reimbursed or you get paid for it. One is the annual wellness visit, which is a yearly visit, which is free to the beneficiary. And it could also be the first time welcome to Medicare visit. And, you know, you can screen for a whole bunch of social and preventative services during that time. In Oregon, we are encouraging cognitive screening, depression screening, social needs screening, all to happen during the annual wellness visit. And obviously, it's not just screening, but then acting on the screening results. And this is paid for by Medicare. The other one is chronic care management. Remember, I said integrated and coordinated care is one of those key strategies. So chronic care management. And there are several ways to get reimbursed for it. There is non-face-to-face, there is face-to-face, there is the psychiatric collaborative care model, which I'll be talking a little bit more in the next few slides. And the lastly is transitional care management, which is certain non-face-to-face services and face-to-face visits for beneficiaries for 30 days after discharge from an acute care setting, like from a hospital or even a skilled nursing facility. You can do transitional care management, which is paid for. Again, that is all in the interest of that integrated and coordinated care. Next slide. Here, I'm not going to go over every one of these, but I'm actually sharing some of the billing codes, the CPT codes that can be used for coordination of care. And you can see it's everything from transitional care management services with moderate medical decision complexity, you know, with more complexity. And as you can see, there are CPT codes kind of built like in a hierarchy here. So I would highly encourage you when you receive this slide deck to look at whether you are maximizing your Medicare billing, and that these are services which you can absolutely provide for better coordination of care and get paid for if you are a Medicare provider. Next slide, please. And this is the model that I was talking about earlier. It's called the psychiatric collaborative care management model. As you know, most older adults do not come to specialty mental health programs like your community mental health programs. It is still highly stigmatized. And this current older cohort, have less mental health literacy, and they prefer to go to their kind of primary care doc or their primary care nurse practitioner. And so this model really fits in very well with that. So in short, it's called the COCM model, is a model of behavioral health integration that enhances usual primary care, particularly for those patients whose conditions are not improving, and they add two services. One is care management support for patients receiving behavioral health treatment, and then most important, regular psychiatric interspecialty consultation. And so who is added to this team? The COCM care team includes a behavioral health care manager who's actually tracking people with behavioral health needs. Many of you may have heard of stepped care, or measurement care, where we are using validated screening tools pre and post or midpoint to check whether people are improving, doing outreach to individuals who may have missed an appointment. That's all part of that care management team. And the second role is the psychiatric consultant, who is essentially a specialist from outside that you bring in to consult. And then the treating practitioner could be a primary care family practice doctor. It could be a nurse practitioner. So this is the care team. So what's different is they have enhanced usual primary care by adding this behavioral health care manager and the psychiatric consultant to a primary care team to get the best results. Next slide. So what should you be doing in your county or your state currently? How can you elevate the behavioral health needs of older adults? First of all, have good data. Know your state. Know the number of older adults, where they live, which part of the state. So have really strong, good data. Then create a value proposition. Remember I said, why should we not focus on older adults? And so having a compelling value proposition is really important. For me, my compelling value proposition in Oregon and within the organization I work with, which is Oregon Health Authority, is an equity proposition. Older adults are also part of that bigger group of Oregonians. We talk about eliminating inequities by 2030 for all Oregonians, and that includes older adults. And so my value proposition is very simple. It's really builds on that equity initiative that Oregon already has. And I always talk about we need to be looking at programming across the lifespan. Often we focus on children or transitional age youth or even younger adults. And often older adults are kind of invisible or even erased. And so I always talk about lifespan approach, and I include that in my value proposition, along with it being an equity imperative and a demographic imperative. And then you make this strong business case. Why? Why should we? When it's 22% of a population, which currently that's what Oregon's older adult population is. And by 2030, we'll have 1 million older adults and very narrow definition of 65 plus. It would be much more if we drop it to 60 and 55, as Miran was suggesting. But making a strong business case of why we can't ignore it and why should we? Why should we be working with older adults? And sadly, very often, we monetize value. We put like a dollar amount on good outcomes. And so you may have to do that, that identifying depression, doing upstream prevention on suicide will prevent, correct, costly interventions way downstream. in crisis, in emergency rooms, in the hospital. So really making a strong business case. I always talk about the double bottom line. Most legislatures and other funders like to know what's the cost. So that's one bottom line. The other bottom line is the social value. That we want to create a state where everyone thrives and is doing well, including older adults. So I call that the double bottom line in your business case. The next point is create an asset map of services and programs for older adults. What does your state currently have? Do you know? And that's an asset map. It could include even volunteer services. So not just your traditional mental health services, they could be social services. So create that asset map. And if you have not, I would say that should be a key thing you should consider doing. And then once you have that asset map, the next step to do is conducting a needs assessment, because that asset map is going to show you very clearly what's going very well in our state for older adults and where are the gaps. Like I've already told you, transportation always rises to the top. Age-specific substance use treatment always rises to the top when we do a needs assessment. Provider training rises to the top. So after you have done that asset mapping, which can be very broad, okay, it's not just service-oriented, it could be trainings, it could be housing, all of that. Conduct your needs assessment. And that's the way to elevate the behavioral health needs of older adults in your state. Next slide. And so here is a model that we use in Oregon through some of the work that I do. Remember, I talked about gaps in services. Once you've established that these are the services we have, wow, this is missing. Those are the gaps in services you've identified. Then you come up with strategies and actions. Remember, I gave you 4 large buckets of strategies. So you can decide, hey, these are those strategies which we are going to pursue to kind of mitigate those gaps. And that would be, you're looking at what would be the system's outcomes. What are some outcomes or results that we are looking for the entire system of care? And ultimately, we want to see what are the outcomes for older adults themselves. Remember, the goal is their well-being and that they are thriving, just like everyone else in the community. So this is a good schema for you to keep in mind when you are doing your needs assessment. For you to walk through. There are some other very good tools, next slide, that I have included in my slide deck. One is called the logic model. I'm not sure how many of you use this, but it essentially breaks down, if you have a program or a pilot or a policy that you're looking to kind of advance, to put it into this logic model, because it's clearly understood then what you're doing. One is inputs. What is the investment? Like, what do you actually need to go into this program or policy? Then it's outputs. Outputs are essentially activities. What are some activities you're going to be doing? And then you look at outcomes, or sometimes we use the word results or impact. Short term, medium term, and long term. Ultimately, we want these to be permanent long-term, impacts. And so this is a really nice, easy model. You can use it for a small program you're developing. You can use it for large statewide programs, or you can even use it for policy development, the logic model. And it's freely available in the public domain. You can download this and use it. Next slide. This other one is very often also used. I use it a lot. It's really easy to use. It's called SWOT analysis. And SWOT is the acronym for strengths, weaknesses, opportunities, threats. So you essentially have this quadrant there. You can see there are four boxes. And you start doing a SWOT analysis, and you may want to start today after this webinar on the state of behavioral health services for older adults. What are the strengths in your state? What are the weaknesses? What are the opportunities? For me, I can tell you one big opportunity I'm really leveraging is the growth of our CCBHC, our Certified Community Behavioral Health Centers, because older adults are a priority population. So for me, that becomes an opportunity. And what are the threats? You know, threat could be lack of a workforce. A threat could be untrained workforce. So I would highly encourage you to use this SWOT analysis if you are not already doing it. And it can be done by anyone. You know, you don't have to be like a manager or a supervisor. You can sit at your desk one day. You could be a case manager or a therapist and do this SWOT analysis from your lens, from your vantage point. And let me tell you, it is really revealing. And again, I use this a lot. Next slide. And so here is the comprehensive strategy that we in Oregon developed to meet the behavioral health needs of older adults. And really, this could be, you know, it could be really replicated like anywhere in the state, in the country. Workforce. We want the workforce to develop core competencies in geriatric behavioral health across sectors, including in the mental health sector. And we want to use varied training pedagogical systems. You know, it could be online, it could be webinars like today, it could be seminars, preceptorships, all kinds of varied systems to really build that qualified workforce. Second one is integrate, and this is not in any order. I'm just giving you three big strategies that we have implemented. Second one is integrating care. Bidirectionally in community mental health program, that means we are integrating primary care services in community mental health programs, and then integrating mental health in primary care, like the model I just talked about, the COCM model. For me, one of the things I'm passionate about is increasing access to and consultation for mental health in long-term care settings, such as nursing homes, also community-based settings such as assisted living, residential care, foster care homes, and then providing platforms for complex care consultations, which are easy to access from a variety of community partners. They can bring a complex care client to this team who really is focused on finding solutions and resources. And then lastly, a big focus on health and wellness promotion. Emotional health, making it accessible and less stigmatized to talk about emotion. Brain health, especially for people with serious mental illness who are at increased risk for developing dementia. Very often, some of the risk factors are modifiable behaviors. Focusing on social connection as a key ingredient for health and wellness for older adults to thrive. And then this is something near and dear to my heart, which I have to still, to be really candid, bring to fruition in a very big way in Oregon, which is public health communications campaign. You know, I see these communication campaigns for drinking and driving. I see for smoking, you know, for many other, for arthritis, for example, but I don't see anything for emotional health or depression. And I just told you, you know, that is the top diagnosis. So what can we do to bring about some public health communication campaigns, which every, you know, older adults can get that message through public campaign. So think about that. And if any of you have any ideas about communication campaigns, please send them my way. I'd love to hear from you. Next slide, please. So remember the first strategy we talked about, it's not in any order, is workforce shortage. There's a general shortage of mental health providers across the country, not just in Oregon. We face it quite severely in Oregon, especially the workforce that is prepared to serve older adults with serious mental illness. Most mental health professionals have very little training in geriatrics, and most geriatricians have very little training in serious mental illness. Core geriatric competencies and geriatric behavioral health competency standards are created in silos. It only happens here, it doesn't happen here. And as you know, older adults, you can't silo older adults. Your brain is here, your body is here. Nope, it doesn't happen that way. As of December 2023, which was just last year, more than half of the US population lives in a mental health professional shortage area. Half. And so the need is great for us to really broaden our view of who is the workforce, who is the mental health workforce, whom do we need to train? Because workforce issues impact access and delivery of services. Next slide, please. So what have we done in Oregon? And this could be a strategy wherever you are. We are upskilling the workforce. The geriatric specialist shortage means we need innovative and multi-level solutions. These strategies include increasing geriatric specialists through unique pathways, building knowledge of older adult mental health and substance use in the generalist, promoting diversity in providers, engaging non-licensed providers, and reforming Medicare billing, which it's already underway. I told you about how they have expanded the licensure types that can serve older adults with behavioral health needs. In Oregon, tapping into the peer and community health worker workforce has been key. This has really, using a peer workforce has been highly successfully utilized in what we call low resource countries in Africa and Asia to deliver mental health and substance use interventions successfully with robust evidence for efficacy, effectiveness, and acceptability. Many of you have heard of the Friendship Bench, which is a depression program which comes out of Zimbabwe, where this wonderful psychiatrist trained, guess whom? Village grandmothers to provide cognitive behavioral therapy or an innovative cognitive behavioral therapy to the women in villages. That was that low resource intervention, which is what they did was upskill volunteers. We are doing a lot of that work in Oregon. So we need to enhance the geriatric mental health and substance use workforce by including and engaging professionals who interface with older adults across settings, including aging service case managers, AAA staff, who work in your area agencies of aging, in long-term care settings. It could be frontline certified nurses, aides. As you can see, this is the call for action, that we need to look beyond just licensed staff to meet the needs of the behavioral health workforce in Oregon and beyond. Next slide. And here's the mandate. All healthcare professionals, and I mean allied healthcare and sectors that are adjacent to healthcare. So all healthcare professionals and community-based organizations that provide support services to older adults must have basic competency in older adult mental health. It's a simple mandate. Now, how you operationalize it is key in your state, but that's a simple mandate. And this is an imperative which the demography is driving from what Mirhan shared earlier. The people accessing mental health services, he said, doubled in less than 20 years. And the population is going to continue to age, at least in the last baby boomers reach age 65. So it becomes a mandate. Is it a mandate in your state? Next slide. So workforce training, one of the greatest barriers to the provision of behavioral health services, a lack of a trained workforce. You may have the workforce, but they don't know how to recognize, identify, assess for behavioral health as it manifests in older adults. So it often goes unrecognized, untreated, with dire outcomes. One study showed that nearly 70% of older adults that died by suicide visited their primary care physician within 1 month of their death. And nobody asked them the suicide question. The other specialty older adults visit 1 month before dying by suicide is orthopedics. So it's primary care orthopedics. Now you have your work cut out. How do we need to train orthopedic staff, primary care staff, to better recognize depression and suicide in their older adults, visiting them for maybe a routine follow-up visit for their diabetes or hypertension or their knee replacement? The Institute of Medicine 2012 report suggests that the breadth and magnitude of inadequate workforce training and workforce shortages have grown to such proportions that no single approach is adequate. It has to be a multi-pronged approach to address this need. Next slide, please. So what is Oregon doing? How are we elevating the behavioral health needs of older adults in Oregon? The one thing that Oregon has done through the Oregon Health Authority is the creation of the Older Adult Behavioral Health Initiative in 2015. So we are now entering our 10th year of this initiative. This initiative funds 24, for the most part, 24 master's level older adult behavioral health specialists at the county level. In Oregon, we have 36 counties. So obviously we have regionalized some areas. And so each of those counties or regions may have one or more than one of these specialists. That we've allocated them based on the population density and the number of older adult that is prevalent in each county. So for every 30,000 older adults who are age 65, the county gets one specialist. So we started this in 2015. Next slide. And very simple. The goal is to better meet the needs of older adults and people living with physical disabilities by improving timely access to care from qualified providers who work together to provide coordinated, quality, culturally responsive behavioral health and wellness services. That is the goal of this initiative. Next slide. And this is what those 24 specialists do. Complex case consultation. Remember, I talked about us developing those platforms where community partners, anyone can bring a complex case for consultation with the goal of finding solutions and resources. This could happen in a more systematic, scheduled way. It can also happen ad hoc by picking up the phone and calling the specialist for help. The other one is really fostering and enhancing coordination and collaboration among multiple sectors: aging services, primary care, transportation, mental health, housing, you just name it. Trying to bring everyone together to provide that collaboration and that coordination. And then a big part of what we do is workforce development. That is developing that qualified workforce that I've been speaking a lot about. And community education is essentially health and wellness promotion directly for older adults, with the goal of really improving the lives of older adults in Oregon. Next slide. So here are very quickly some of the outcomes that we have been looking at. Older adults should be recognized as a priority population, have timely access to services that have demonstrated effectiveness, have their signs and symptoms recognized as behavioral health needs, receive help from knowledgeable and skilled providers of all types, have information and tools to promote mental health and well-being, rarely experience evictions from housing, and they experience successful resolution of complex issues through this consultation process that I spoke about. So those are kind of our big outcomes. You know, if you remember the logic model, that would be the very last section, you know, the impact. This is what we are working on. Next slide. And so what are we doing for the workforce? We want to increase their knowledge and skills in treating mental health conditions in older adults, provide high quality training in common evidence-based best practices found to be effective in meeting the needs of older adults, such as behavioral activation, pearls, I'll be talking a little bit about it, problem-solving treatment, and many others, and including the voice of lived experience from individuals experiencing mental health conditions in late life, and peers providing this support to them. Next slide. Here is just a sample of the trainings we've offered through October 2017 and through March 2020. Almost 10,000 participants attended one of our over 650 workforce development trainings. 10,000. You know, these were not unduplicated, but total 10,000. And these trainings reached, as you can see, a vast cross-section of professionals, paraprofessionals, such as behavioral health providers, direct service providers, administrators, long-term care staff, community partners. And almost all of them, you know, 88% reported gaining knowledge, and that was useful. And 95% say that they have confidence, high confidence that they will be able to use this. For example, we do a training on depression where we actually encourage the use of a screening instrument such as a PHQ-9 or a GDS-15. And we actually teach them, how do you administer it? How do you interpret the score? How should you act on that? Should you act on that score? And so that was the confidence here that we are reporting at 95%. Next slide. And then remember the complex care consultations I talked about. This data was just compiled in 2023. You know, for that time period, we've done from over 7,000 complex care consultations. 91% of those complex care consultations had 3+ complexities or diagnoses. And as you can see, these are the kind of buckets of complexities we look at: physical and medical, neurological and cognitive, including lack of decision-making and co-occurring dementia, behavioral health, such as serious mental illness or serious mental illness with disruptive behaviors. Next bucket is social or individual. That's where social connection, poor family support, finances, all of that falls into that bucket, which is making this case complex. And lastly, system navigation, understanding eligibility. Which Medicare plan should I go on to? Do I qualify for in-home services? Those are the kinds of, the complex issues that we are consulting on. So it's not just the mental health diagnosis, but it's all of this. Often it's 3 or 4 of these. And look at that, 42% of the cases often lack community resources to address this need, especially for older adults. Next slide. And then a big part of our job is challenging those silos by really enhancing and fostering cross-sector collaboration, building bridges between community mental health programs and aging services, creating complex care, multi-sector, multidisciplinary teams, those complex care teams that I talked about, promoting behavioral health training for aging service providers and home care workforce. Remember, I said that's the mandate. Creating community partner groups at the county level to identify and elevate your regional needs for older adults. Very important, training primary care providers to better serve the behavioral health needs of older adults. You know, Oregon is very big. It's a very big state, 9th in terms of square miles. Much of it is rural, chronic shortage area. And so it becomes key for us to train primary care, whether you're a federally qualified health center or a rural health center. We want to train every staff there in behavioral health needs, including suicide prevention. Next slide. Scaling depression care. Remember, I kept talking about primary diagnosis. Primary diagnosis is depression. We want to scale depression care for older adults and prevent suicide deaths. So in partnership with OHA's CDC Comprehensive Suicide Prevention Grant, which our public health department received, we are focusing on mitigating suicide by 10% in 5 years for older adults and rural adults. One thing we've done is we've rolled out this evidence-based depression treatment called PEARLS from the University of Washington. PEARL stands for Program to Encourage Active, Rewarding Lives for Seniors. So it's an effective depression treatment. And we adapted it with the blessings of University of Washington to be presented in a group format as opposed to individual therapy. And we are using the lens of health and wellness promotion. We are providing it in senior centers, churches, housing. One specialist is providing it in a fire station. So we are scaling depression in a big way. We are expanding the workforce by training non-traditional workforce such as peers and volunteers and community health workers to provide evidence-based depression treatment to older adults in their homes or community settings, where we have trained them in a curriculum, in a prescribed curriculum, and they get clinical supervision, but they are actually going into homes to provide it. We have illuminated the need to mitigate social isolation and loneliness and promote social connection as a protective factor for both depression and suicide. Next slide. We are doing health and wellness promotion for older adults, upstream prevention initiatives to promote resilience and increase protective factors, utilizing cafe models. Our cafes are aging cafes, death cafe, memory cafe, mental health cafes. In fact, one of our specialists did a national presentation through the, I think it was last month, through the National Association of Wellbeing. We are depression care as health promotion in community settings. We are actively teaching and disseminating behavioral activation, which is an effective depression treatment in community settings. We are involved with falls prevention and mobility as a behavioral health intervention. Did you know that there's a unique form of anxiety called fear of falling, and that mobility and walking mitigate depression? We are promoting social connection by promoting circle of friends, intergenerational activities, connection planning, which is a 3-session CBT class for enhancing your social connections. And we are doing advanced care planning and psychiatric advanced care planning for our older population and some of our more marginalized populations. Next slide. What are some positive developments currently? Ongoing development and expansion of certified community behavioral health programs, the CCBHCs. Does your state have a CCBHC? Have you connected with the CCBHC to see whether they are trained to meet the needs of older adults? Oregon's integrated approach to no wrong door. You can go into social services and get assessed for depression, or you can go to a primary care clinic and your depression is recognized. Crisis and mobile workforce trainings that include the behavioral health needs of older adults in crisis. Next slide. We have just funded the Oregon Health Authority with our block grant funds, created the first Center for Excellence on Behavioral Health and Aging called OSEBA. And if I'm not mistaken, it's the first of its kind on the West Coast. And I'm very thrilled, that this came to fruition after it took, it kind of percolated for 7 years before we could actually fund it. Next slide. One of the things that we are going to do through this Center for Excellence is to hold every year a annual conference, which will focus on older adults, and it will be open widely to a broad cross-section of people who work with older adults. This is going to happen this year on October 16th and 17th, 2024. It will be an in-person only event. Next slide. Along with that, one of the deliverables that I had included for our Center for Excellence was building a leadership academy to identify, nurture, and cultivate the next generation of geriatric behavioral health leaders. And so I'm very happy to say that our first leadership academy will also be inaugurated in October. And we will be offering every year one leadership academy for the future leaders in Oregon. Next slide. Our 988, 2 years ago, 988 became national. I was at the Nashville conference, and the 988 folks reported over 10 million contacts nationally. In Oregon, you can see it was 53,235, which was a 74% increase from before 988. Next slide. And we are following this framework, which is a national framework for 988, someone to talk to, someone to respond, and a place to go to. Next slide. And here is the Oregon's crisis ecological system. You can see the 988 is both talks, text, chat. By the way, it's ASL too, which I was thrilled to hear. Mobile crisis intervention teams, which were, remember I talked about special training for them in meeting the behavioral health needs of older adults. Crisis stabilization centers, extended stay respite centers, a whole slew of outpatient programs geared towards more intensive interventions, warm lines or sub-crisis lines, community education and awareness using a curriculum such as mental health first aid, question, persuade, refer, Oregon CALM, which is a firearms reduction training, health and wellness promotion that I talked about. Or we are actually promoting PEARLS as health and wellness promotion. And then our 1115 waiver, which provides for social needs. So this is kind of our larger crisis ecological system. So it's not just 988. What happens after 988 is equally important. Next slide. This is the Behavioral Health Training Summit I talked about, where we are training the mobile response teams. And there is, we hold it every year in person, but throughout the year, it's also offered in interactive webinars, and I'm very much a part of that, faculty. Next slide. We also have the Senior Loneliness Line, which is a sub-crisis telephone line for older adults, their families, and their caregivers. It is now in its 4th year. And on average, we receive about 1,200 calls a month, and they're from all over Oregon. Next slide. We also have developed several echo models for case-based learning, and one of the ones that I'm most proud of is the behavioral health geriatric nursing home echo, and the substance use echo for licensed community-based residential staff, where we are increasing the knowledge and skill of frontline staff in long-term care setting to better work with older adults who are experiencing behavioral health and substance use issues. One of them was funded by block grant, and the nursing home was funded by the civil penalty fund, which is, by the way, available to all of you in each of your state has. So we wrote a proposal and we got funded by the civil penalty fund. Next slide. I'm also very thrilled that OHA has had the foresight to fund this. It was, I think, maybe we took the idea from Massachusetts. It's called the Oregon Psychiatric Assessment Line for adults. So it's a telephone line, OPAL A for short, where anyone, primary care, medical provider of any kind, can call this consultation line during the week and get first-hand consultation with a board-certified psychiatric and medical professional who answers the phone, and you can talk with them about complex medications, complex diagnosis. Look at between 2018 and 2024, almost 900 consultations for older adults age 65 and older. And if we drop the age, I'm sure it's much higher. And the majority of people who are calling, I looked at some of the data, were nurse practitioners from very rural areas where they needed help with consultation. So this plays a vital link in that continuum of services. So remember, when you do your gaps analysis, do you have something like this? Next slide. We have a Medicaid waiver, which we just got for 5 years, 22 to 27. And why is this important? Because first of all, older adults are a priority, and that we are focusing for the first time. I think we were one of the first states, along with 4 others, to focus on social determinants of health. So Oregon will be focusing on, for their Medicaid recipients, on housing, climate, nutrition, for people facing challenging situations such as homelessness, extreme weather events, which often impact older adults in much more dire ways than younger people, leaving like a state or tribal custody or a state hospital, and nutrition. Next slide. what are some funding sources? SAMHSA and NASHBID asked me, how can you fund some of these programs that I've been talking about? Block grant, Medicaid waivers. And, that's a whole different talk. I'm just giving you some food for thought for you to explore. Legislative budgets. So really advocating. Senior bonds and levies, which are generally voter-approved ballot measures. So also mental health tasks. California has had this mental health task, which was voter-approved since, I think, 2004. It's a 1% tax on people who earn more than $1 million. It funds their mental health program. So mental health tax. And then there are social impact bonds. These really come from private donors, venture capitalists, and they're called social impact bonds. These are some ways to fund some of the programs that I've been talking about. Oregon Health Authority, the big program that I talked about, the Older Adult Behavioral Health Initiative, was initially funding procured from the legislature, and now Oregon Health Authority continues to fund it through our general funds. Next slide. Very lastly, here are all my resources. I'm not going to go over them. Next slide too. Again, more resources that you may want to check out. I don't know how many of you know about the E4 Center of Excellence for Behavioral Health Disparities and Aging. If you do not know about it, I would highly, highly encourage you to check out their resources. Absolutely wonderful resources, trainings, other tools, especially they have a very good tool on collaboration. There are some SAMHSA resources too that I would absolutely encourage you to look at. I would also encourage you to look at the Medicare Learning Network and the Medicare fact sheet link that I've put there. Last slide. And I thank you all. I talked fast. I gave you a lot of information. I hope some of it you will take back to your states and start a conversation. My email is here. I welcome contact by email. Thank you.
Thank you, Nirmala. That was, as you said, a tremendous amount of information. And luckily, we will be sharing all of these slides, so you can look through these later. We have a few questions for you, and I know we have about 8 minutes or so left.
Okay.
So just jump right in. The first question we got is there someone we can reach out to about Medicare in our state to get information about the resources that are reimbursable?
There are some links on that last page. I said, if you go to those links, it gives you all the resources for that, for how to get reimbursed for Medicare.
Okay.
I am personally promoting it at all our big venues. I give all the links. We've created a fact sheet because very often people don't know, what can you bill for, and so they just don't do that service. But very good question.
Okay, and I did notice that one of the links on your resource sheet there was to CMS website.
Sure,
so.
And if whoever asked that question, you're welcome to write to me directly too, and I can also help you navigate some of those resources. My email will be on the slides.
Okay, thank you. And then another question is you mentioned that 70%, a figure of 70% of completed suicides, and what method did they use to complete suicide? And are there any numbers that look at previous attempts?
So this study was only looking at, the visits to primary care. A majority, if I recall the study, were men, and it was firearms.
Sure. Okay.
So we are doing a ton of work in Oregon about lethal means reduction because, we are very rural. Much of the state is rural. And as you get more rural in Oregon, the gun ownership goes up and it is more of an aging population. So yes, we are doing a ton of interventions, including extreme risk protection orders, awareness for county level staff to know about that. So if anyone is at risk, that we can petition the court to remove the guns if they are not giving them up, willingly. So
Okay. Okay. And then the next question, I know Dave from Nashville has provided an answer for it, but also want to give you an option to answer it. Do you know of specific programs in which older adult peer supports have been shown to be an effective approach to addressing the needs of older adults with SMI? And then further goes on to provide the context of there are an increasing number of older adults with SMI entering nursing facilities, and having peer services in such facilities would be great.
Right. I'm just going to take the second half first.
Sure.
As we speak, I was at the Nashville annual meeting, and there was a very nice presentation of peer programs. And one of the peer programs was from they were from Delaware, the people presenting, and they had a recovery peer in a long-term care setting. And I had been thinking about that. In fact, I'd already done some preliminary research on it. And I'm connecting with Delaware next week because I'm planning to do exactly that. We are looking at piloting a program using a recovery peer in one of our long-term care residential settings in one of, in a more urban area. So absolutely, I would highly encourage you to look at it, look at doing something like that. The other question was on, what was the first half was on?
Just do you know of such programs? It sounds like Delaware is the
in long-term care in Oregon, we have piloted several peer programs. Some are peer, some are community health workers, where we are delivering depression treatment. One was modified pearls. We modified pearls, and we delivered it by community health workers in a federally qualified health center and at a food site, at a congregate meal site. Which was more individual on one-on-one, not the group one that I talked about. We have currently another pilot where we are delivering, where we are going to deliver just screening and SBIRT in two older adults in community settings, which is already underway. By the way, we are evaluating all of them. So the first program was evaluated. Whoever asked that question, if you would like that evaluation, you can write to me and we can let you know. And then we have a third pilot going on in one of our very rural counties where we are using, I don't know how many of you are familiar with the BRIGHT curriculum, which is out of the University of Florida, which combines both substance use and depression. So we've trained peers in it, and they are delivering it in people's homes. We are having a little bit of a issue at times to engage older adults in that, but we are plodding along, and I'm waiting to see what the evaluation will state. So we have at least 4 active peer programs going on right now.
Okay, excellent. And Oregon always does a great job with their evaluation. So do follow up if you want to learn more about that. And one, I guess maybe 2 more questions here if we have time from both, is one, can you again speak a little bit about the concept of health span and the number of chronic conditions? Okay.
So health span is essentially a concept of how long are you healthy, free of any debilitating chronic illnesses. Say like severe arthritis, COPD, severe cardiovascular disease. So for the average American, our health span is 66 years old. After age 66, most Americans have 1, 2, 3, 4 chronic illnesses, which could include depression with arthritis, with some kind of respiratory disease, could be hypertension, could be diabetes, which impacts their quality of life and causes, disability. So health span is how can we keep people healthy longer than age 66? And for me, that's a policy quest. What do we need to do? One thing we are doing is we are promoting brain health. We are promoting physical activity. Stay active, keep your mobility. So that's the concept of health span. The usual concept is lifespan or life expectancy, which doesn't take into account, what's your quality of life. It's just like how long you live. And our goal is we want people to live well and thrive as long as they can without significant disability, whether physical or emotional. Yes, blue zones. I teach a whole class on blue zones. So blue zones living. And I subtitle it How to Live to Be 100.
Okay. Okay, and I don't think we have any more time for questions. Trevor, there, I did see your question, but if you want to email Nirmala, I'm sure she'd be happy to answer you via email. And if you haven't yet, please answer the survey that was provided to you. And otherwise, thank you so much to Nirmala and to SAMHSA for sponsoring this webinar, and to NASHBID for helping organize it. So I hope you have a great afternoon.
Thank you, everyone. Stay well. Bye.